One, as you hear the electronic voice, this meeting is being recorded, so you will have access to this later on our website. So if you want to share this, if you want to go back and listen to it again, you will have that option. My name is Anissa Mitchell, and I'm with PMD Alliance, and I want to welcome you today to our Lunch with Docs. We're going to be discussing fatigue. Before we get into the presentation, I will just do a bit of our housekeeping, typical things that we do. The first thing I want to note is that we do have the transcription that can occur at the bottom of your screen. It's on for me right now. You might be seeing it, so it's transcribing what is being said. If you like that, you can keep it. You can hover over it and you can move it around on your screen if you like. If you don't like it, you can go over to where it says live transcription and you click that and it'll pop up a little box and you can click to hide the subtitles. The other thing is that we are going to keep you muted for this program. We have quite a few people that's registered for it, which is very exciting. I guess everybody wants to know what to do about fatigue. And I am going to invite you to chat. So if you open up your chat box, then you can ask your questions throughout the presentation today. Feel free to give me a shout out and let us know where you're joining us from. We love to see where all of our friends are from and get to know you even better. So I want to introduce our speaker. Some of you may have seen him. He's been on a couple times now. He's starting to become a regular. I just told him. This is Dr. Friedman, and he is the chief of the Butler Hospital's Movement Disorders program in Rhode Island. He's also a professor and the chief of the Division of Movement Disorders in the Department of Neurology at the Warren Alpert Medical School at Brown University. Now, this is an area that I know Dr. Friedman has had some interest and done some work in. I know that he wrote a blog about fatigue back in 2017 for the Movement Disorder Society. And I also found an article that he had written for current treatment options in neurology. And I wanted to quote it because I thought it was an interesting statement that he had. It said, fatigue affects about half of all Parkinson's patients and has a major impact on quality of life. Fatigue is the single most important reason cited for medical disability insurance claims by PD patients in the United States, and patients suffer from both physical and mental fatigue. So I'm very anxious to pass this over to Dr. Friedman so he can expand on that, and I welcome him.
Okay. Let me get this up and running. Okay, so you see my slides?
Yep.
Let me get to the beginning. So thank you very much for your kind introduction, and thank you even more for inviting me to do this. I enjoy talking to Parkinson's disease patients since that's how I spend my day every day at work, and it's nice to be able to address patients directly and to treat some of the problems that are so common in Parkinson's disease. And my own general area of research interest over several decades really has been focused on behavioral problems in Parkinson's disease. And these are often not recognized either by patients or their doctors as being part of Parkinson's disease, and often don't get the same attention as tremors or stiffness or slowness. And yet, as you pointed out in that introduction, they often are more important in determining quality of life in people with Parkinson's disease than the motor features. Now, I got interested in fatigue, and pretty similarly to the way I've got interested in other areas related to Parkinson's, was a result of an interaction with one of my patients. I had this patient who was, this is a long time ago, he was probably in his 40s, late 40s, and his Parkinson's disease was pretty mild, and he was working full-time He did some outdoor work. I believe he helped build swimming pools, but operated heavy duty equipment most of the time. And he told me that working was not a problem for him. He worked, but at the end of the day, he was just so tired, fatigued, that when he came home, all he could do was lie on the sofa, watch TV, eat dinner, and then he would go to sleep. And he wasn't sleepy. He was just lacking in energy. He felt all used up. He felt wasted, that he had worked so hard during the day that he just had no energy left to spare for anything else. And it struck me as such a unexpected sort of observation, because at that time, no one had ever talked about fatigue in Parkinson's disease. And in fact, in a very famous paper that was written by Doctors Hone and Yar, who developed the Hone and Yar scale for assessing Parkinson's disease, when they looked at their experience with levodopa back in the late 1960s, they talked about what brought the patient to the hospital, to their clinic, what their major complaint was. And I think it was something like 2 out of 600 or so patients reported fatigue was why they came. Now, of course, they didn't ask anybody about fatigue, or else they would have found out that it was a fairly common sort of problem. But fatigue is a kind of problem that patients often don't bring up because it's not something that other people can see, and which often, at least until recently, isn't thought of as part of the illness. So when this patient told me about fatigue being his major problem, and yet he looked like a pretty normal person without, all of the signs and symptoms that people with Parkinson's have, it got me to wondering how common a problem this was. And when I started asking patients about it, it turns out to be a very, very common problem. And this is the sort of thing that has changed over the past 2 or 3 decades in our approach to Parkinson's disease, that we've come to recognize that what we lump together as non-motor features of Parkinson's disease or non-motor symptoms are really as crucial to improving a patient's quality of life as the motor features, motor being movement features, stiffness, slowness, tremor, balance problems, speech problems. But these things that don't appear on the surface. If I look at you, I can't say, boy, this guy looks fatigued. You might look normal. And so we started studying fatigue. And the first question, of course, to ask is, what do we mean when we use the word fatigue? And it turns out that this is not such a straightforward question. So in one paper that was written relatively recently, I think, they describe fatigue, and I'm quoting, a sense of tiredness, lack of energy, or need for increased effort, often perceived as overwhelming, pervasive, and disabling. Okay? So fatigue is a sense of tiredness. However, I want to point out the second definition that I got off the internet using Dr. Google: feeling overtired with low energy and a strong desire to sleep that interferes with normal daily activities. And so here is the problem, and I think it extends beyond just English language to other languages as well, although I only speak English, so I can't really say that for certain. But when we use the word tired in English, it has an ambiguous meaning. For many people, we use the word tired to mean that we are sleepy. The same person, including myself, of course, might use the word tired to mean fatigued. So what's the difference between fatigue and sleepy? And the answer is pretty simple in a way, which is when you're sleepy, and you take a nap and then you feel less sleepy, and so you're less tired. Fatigue is a sense of lacking in energy. When you do something that's physically demanding, especially for a long period of time, like you run a marathon, for example, at the end of the marathon, you are presumably very fatigued. You are lacking in energy. You don't have the, get up and go to do the things that might need to be done. You want to rest. And when you rest, you'll sit, you'll probably do nothing. You may watch TV, you may have conversations, you may read a book, but you're not necessarily going to take a nap. You're feeling lacking in energy. Whereas the person who's sleepy is going to just fall asleep. They drive in a car, hopefully they're not the driver, they fall asleep. They start reading a book, they fall asleep. They fall asleep easily. They're tired. We all are tired at some point because we might not have gotten enough sleep. We all are fatigued at some point because we've used up all our energy doing something. But with Parkinson's disease, patients have a feeling of chronically lacking energy. They feel tired in the sense of not having energy to do things. So when you look at synonyms for fatigue, we use tiredness, which, as I pointed out, is not necessarily a good term because it overlaps with, in our understanding, with sleepiness. People feel weary, they feel exhausted, lassitude, which really means exhausted, not having energy, innervation, lacking nerve energy, lethargy, feeble, weary, feeling heavy, sometimes described brain fog, although that may be something a little bit different. And it's important when we talk about feeling tired that we distinguish between fatigue and sleepiness. Sleepiness is due to a certain number of potential problems, and fatigue is something different. So, unfortunately, in Parkinson's disease, a lot of Parkinson patients are sleepy. They have what we call excessive daytime sleepiness. That is, they're sleepy all the time. And that's different than fatigue, although patients may have both. So there are a lot of patients who will say, I'm sleepy all the time. I watch TV. I can't watch till the end of the program because I fall asleep. I can't read the newspaper in one sitting because I fall asleep. And those patients may also suffer from fatigue. If you're excessively sleepy, there are a number of things that we think about. First of all, most, or at least a large percentage of older people wake up at night to go to the bathroom. So, men often have an enlarged prostate. Women have maybe a history of urinary infections, which can damage the urethra. They've given birth, which can also damage the urinary system. And so older people often wake up 2, 3, 4, or even more times a night to urinate. So if you have Parkinson's disease, it may not be so easy to get out of bed. It may be difficult to get back into bed. It may be difficult to get comfortable enough to fall asleep again. And then shortly after you fall asleep, you wake up because you have to urinate again. So people with those types of problems, we call it nocturia, that is urinating at night, will be sleepy just because they don't have enough sleep at night. Parkinson patients often have sleep problems because they have difficulty getting comfortable. And although the doctors, at least I was taught, used to believe that once you're asleep, your tremor goes away. It turns out, of course, that that's not completely true. Tremor goes away during the deeper portions of sleep, but during light portions of sleep, it comes back. And it's very common for patients to complain that they were awakened by their tremor. So they take medicine, they get better, they get comfortable, they fall asleep, and then 2 hours later, They may have a dream that makes them nervous, or the medicines are wearing off and they start having tremor and it wakes them up. And then it's hard falling back to sleep again. Older people in general often have difficulty sleeping through the night. Parkinson patients may have an increased rate of developing sleep apnea. So sleep apnea is a disorder in which people stop breathing when they fall into a deep stage of sleep, and that awakens them to a lighter stage of sleep. So they may not fully wake up and they may not know that they've been disturbed in their sleep, but they don't get enough good sleep, enough refreshing sleep, so that they may sleep 10 or 11 hours at night without getting up to urinate. And when they wake up in the morning, they eat breakfast and they go back to sleep. So sleep apnea occurs. And unlike in the general population, where it typically occurs, excuse me, in people who are overweight, often have a history of having smoked cigarettes, it may happen to people who are of normal weight, who have no lung disease at all in Parkinson's disease. So sleep apnea is pretty common in Parkinson's. Plus the medicines that we use in Parkinson's disease. Levodopa makes some people sleepy. Dopamine agonists often are associated with increased sleepiness as well. Antidepressants or anti-anxiety drugs may cause sleepiness. So sleepiness is very, very common. And the treatment for that is quite different than how we address the problem of fatigue. And then people who feel tired, both from sleepiness or fatigue, may have trouble concentrating or doing anything. So they may feel less motivated, less interested in doing things. And there are different kinds of fatigue. So fatigue is something that we generally can't measure, at least not the kind of fatigue I'm talking about. People have muscle fatigue, which can be measured. That's objective. That means it's not the result of someone's impression of a problem. It's something that can be measured in terms of actual physical data. So if you move your muscle, if you contract your muscle against resistance, that is, you lift a weight, and you keep doing it repetitively, after a while, your muscle will object. It will feel fatigued. There are biochemical changes that take place as a result of repeated contractions of the muscle, and a fall off in the energy in the muscle, the strength of the muscle, can be measured, and it can be plotted. You can see a graph of this. But when you have fatigue that's emotional fatigue or cognitive fatigue, that is, you have been coping with some very important stress. You have a child who's ill or needy in some way. You yourself are facing changes in your lifestyle, perhaps as a result of the Parkinson's disease. You may have financial concerns, and dealing with this on a regular basis can be fatiguing. It makes it harder for you to be motivated to do anything. Cognitive fatigue is a similar sort of thing. You can remember perhaps back when you were in school and you'd have to concentrate on learning certain things, particularly things that were difficult for you to learn. And it wouldn't be too long before you had some sort of cognitive fatigue, that you had difficulty with your concentration, you had difficulty getting the wheels to spin to analyze what you needed to analyze and understand whatever principles you were trying to learn as you were studying. And then there is the physical fatigue, which is non-objective. In other words, unlike muscle fatigue, where you can measure the loss of strength of a muscle, non-objective physical fatigue, you look normal. You just don't have energy. It's a common problem, for example, for fatigue persons to complain that they would love to exercise. They know that exercise is important for people with Parkinson's disease, but they just don't have the energy to do it. They don't have the energy to get up and socialize. They don't have the energy to do the chores around their house. That everything is just so hard that they can't do it. And it makes them feel badly, of course. It often makes them feel depressed. Closely related to just a constant state of physical fatigue is easy fatigue or fatigability. That a person may not feel that they're particularly tired, but they have learned that their energy runs low very quickly. So it's like having a faulty battery. So you can think of the fatigue that people with Parkinson's mostly suffer from is like a battery problem. The battery could be out of energy or it could have a small amount of energy, but recharging takes a long time, unfortunately, so that yes, they can get up and walk, but they can't walk a mile like they used to, or the half mile or a quarter mile, that they fatigue so easily that oftentimes they stop even trying to do things, even though they know that it will be helpful. So it's hard to measure fatigue because we don't have objective measures. And if you measure anything that's subjective, it's going to be hard to tell. If you try to, count to explain to somebody how severe a pain is, you can say, well, it's a 6 out of 10 or an 8 out of 10. But your 8 out of 10 may be very different than somebody else's 8 out of 10. That you might not complain until it's really, really severe. And you think another person is complaining when it's really pretty mild. So there's a large variation in how people may perceive their own sense of fatigue. And of course, for any particular person, that's really all that counts. But in terms of trying to study it, it's very difficult. So we use subjective measures. You can rate your fatigue on a scale of 0 to 10. I have no fatigue at all. I feel very energetic. Or 10, which is you're so fatigued, you feel that you may have trouble breathing even. Obviously, you don't, but you may feel like every single thing you do is really a challenge. Other people might measure your fatigue by looking at your willingness to take on new tasks or responsibilities. So patients who have a problem and the problem improves with treatment, but still remains a problem, often have difficulty assessing how much benefit they got from an intervention. So, for example, I may treat somebody with levodopa, and when they come back, they tell me they're not any better. And the family may look flabbergasted, and they'll say, "What do you mean you're not any better? You couldn't get out of a chair before. Now you can. You couldn't walk to the car before without, taking a rest, and now you can. You couldn't put on your shirt before, and now you can." And the person says, "Yeah, but look at my hand, and the hand is trembling." So a person sometimes can't make that assessment. Or if you treat somebody for pain, for example, people with back pain, they often go through lots of different kinds of therapy programs where the goal is to make them more functional because they may not be able to get rid of the pain. And the patient says, the pain isn't any better. This treatment was a failure. And again, other people, a caregiver will say, "Well, gee, before you wouldn't go walking and now you're walking a mile a day. Before you were using a cane and you're not using a cane. Before you couldn't even make your meals and now you're making your meals." But the patient will say, "Well, yeah, but my pain is still terrible." And in fact, it undoubtedly is still terrible, but nevertheless, you can measure improvement by changes in how the person behaves. And fatigue would be one of those types of problems. It's not like taking a temperature where you get a number out. It's not like taking blood pressure where you can say, your systolic went from 160, now it's 120. But we can say, well, now you're socializing. Now you are exercising. Now you are doing these things that you didn't do before. And fatigue is closely related to motivation. People who are fatigued, of course, are less likely to take on new tasks. They're less likely to become interested in taking up a new hobby. They're less likely to be interested in going on a trip to see a friend, to go sightseeing, to go to a movie, to go out for dinner, because it's too hard for them. So there's a very close relationship between fatigue and motivation, even though we usually don't think of the two as being so closely identified. And similarly, by talking about measuring fatigue by seeing if a person takes on new tasks or responsibilities, we can also measure how active people are. And one of the schemes that people have used for measuring fatigue is to have people take, to fill out questionnaires on how much time they have taken to exercise, how often they travel outside their house, how often they do various physical or mental tasks, whether they're reading books more than they used to, whether they are engaging with their grandchildren more than they used to. So we measure fatigue in an indirect way because we don't have any objective measure for what's gone wrong for us to measure. Now, this is a very important issue. The question is fatigue physiological or is it psychological? Very often, because like my patient who initially got me interested in the topic of fatigue, he looked normal or pretty normal. He looked like he had very mild Parkinson's disease, and you'd figure, well, this guy may be not as efficient at doing chores as he used to be, but he's probably better than a lot of people his age who don't have Parkinson's disease. And yet, at the end of a typical day that, say, 3 years before would not have slowed him down much, now all of a sudden, he's basically feeling devastated at the end of the day. He's totally out of energy. And so, of course, he doesn't want to do anything. And it's common, for the family to think, oh, he's just depressed. He's not motivated. The power of positive thinking. If he only thought in terms of not worrying about his Parkinson's disease, he'd be able to get up and do things. Well, that may be playing a role. And certainly when people become depressed, they may become fatigued as well. But I think we can clearly say that fatigue is also partly physiological. We don't have, I see in the second bullet point here, I say that we have no biomarker for fatigue. A biomarker is an objectively measurable change in a person that is a substitute or an indicator of a physiological process. So, for example, in Parkinson's disease, we have crude measures for dopamine. And there's some relationship, it's not as close as we like to think, between how much dopamine you have in your body and your slowness and stiffness and tremors, okay? But it is a marker for fatigue. When we measure, say, your PSA, that is the prostate-specific antigen, that's a biomarker for prostate cancer. The total number doesn't necessarily tell you that your prostate cancer is much worse, but it tells you that it's active. And when that biomarker goes from normal to abnormal, generally, in a patient who has a history of prostate cancer, that's a strong indicator that their cancer may have returned. So we use that as a biomarker. There are other biomarkers for types of cancers where the activity of what they measure in your bloodstream is an indicator of how active the cancer is. We don't have such a marker for fatigue. So we can't tell whether something, and we have no measure for psychological problems either. So when you ask the question, is fatigue physiological or psychological? I say that the answer is yes, meaning that it's physiological and it may also be psychological. So why do I think it may be physiological? First of all, because it's so common. As Ms. Mitchell indicated in the introduction, we found, and this has been replicated around the world in different cultures, in different parts of the world, that about 50% of people with Parkinson's disease will rate fatigue as one of their 3 worst symptoms. And about 1/3 of Parkinson patients rate fatigue as their single worst symptom. Well, given that culture has a strong influence on our psychological response to problems, on our physiological responses as well, that would indicate that this is a cross-cultural phenomenon and more likely to be physiological. Perhaps even more telling, I think, is the fact that many people who are diagnosed with Parkinson's disease, at the time of diagnosis, before they knew they had Parkinson's, will report that they've been fatigued for a few years before any of the external signs that allow the diagnosis of Parkinson's to be made was present. So people feel fatigued before they develop the motor features of Parkinson's disease. There are other disorders where there's clearly a relationship between physiology and fatigue. People who get radiation treatment almost always feel fatigue, and they can chart out when the person will feel fatigue. So whether a person is depressed or not depressed, after a certain number of treatments, they are predicted to most likely have fatigue, and the fatigue will persist for a certain amount of time, and then it will resolve. So there's clearly a dose-response relationship for that. We know that people with congestive heart failure will often have fatigue, and that can also be correlated to the severity of their congestive heart failure. On the other hand, there are a number of different causes for fatigue. So when do we consider fatigue pathological? We all feel fatigued, just like we all feel depressed from time to time. We feel melancholic at times. We all feel fatigued. You may wake up feeling fatigued. You may wake up one day, even though you had a good night's sleep, and say, gee, I just don't have any energy. I don't want to do this, or I don't want to do that. And there's no clear marker other than the patient who has the fatigue with Parkinson's disease will feel that the fatigue is excessive compared to the way they used to feel. They will report that the fatigue feels different than it used to. Everybody is used to feeling tired. We all feel tired from time to time. But the person with Parkinson's will say that this fatigue is worse than it used to be, and it feels different. It has a different quality of feeling uncomfortable. And I think part of that may have to do with the fact that it doesn't go away. It tends to be there most of the time. So that with a normal person feeling fatigue, the fatigue tends to come and go and is diminished. And you know, if you wake up in the morning feeling fatigued, it's going to be gone by the end of the day, or it'll be gone by tomorrow. But I guess the bottom line is when it interferes in your life in a way that it doesn't for others, that you are restricted by in your normal activities because of fatigue. At that point, it has interfered with your quality of life, and at that point, it becomes somewhat pathological. Now, having said that, I need to backtrack a little bit, because as probably most of you have experienced, that when we age, we fatigue more easily than we used to, and we may have a lot less energy than we used to. And so you have to really compare yourself to other people, in your age group. So fatigue is unfortunately a very common problem. And it's not just in Parkinson's disease. I've already mentioned some of the other disorders in which fatigue appears prominently. So if we start off with the general population, when you look at the primary complaint of people going to their primary care doctor, their PCP, people under the age of 65, adults under the age of 65, somewhere between 5 to 10% of seemingly normal, healthy people will bring fatigue as their major complaint in people between the ages of 18 and 65. So that's a pretty common problem in the non-aged population, in people who don't have Parkinson's and may not have any identifiable illness as the explanation for their fatigue. Now, fatigue is seen, as I mentioned, in a number of different disorders. So the ones that are most relevant for Parkinson's disease are the illnesses that are associated with Parkinson's, like depression and like anxiety. Both of those conditions are associated with increased risk of fatigue in the general population. And in fact, among the symptoms that allow for the diagnosis of depression is fatigue. So there are a number of different symptoms that are used for saying whether a person is depressed or is not depressed, and one of them is fatigue. And yet fatigue is a common problem in Parkinson's disease, even in people who are not depressed. But since we know that depression affects somewhere between 30 and 50% of people with Parkinson's, fatigue is a common problem for depression. How do you separate out the fatigue of depression from the fatigue of Parkinson's disease? And the answer is we don't know how to do it. They seem to be the same. The patient can't recognize it. The patient can't say, oh, I'm fatigued now because I'm depressed, rather, or no, the fatigue isn't from the depression, it's from the Parkinson's disease. Well, they're all related to each other, unfortunately. And the same thing for anxiety. If the anxiety goes away and the fatigue goes away, then you could say the fatigue was from the anxiety. If the depression goes away with treatment and the fatigue goes away, you'd say that fatigue was due to the depression. If it doesn't go away, you still can't be sure, because when you treat people with major depression who don't have Parkinson's disease and the depression gets better, their fatigue frequently does not get better. So there's a very peculiar relationship between, say, depression and anxiety and fatigue that we can't necessarily pin down. Apathy. Apathy is a common problem in Parkinson's. Apathy means lack of emotional interest, lack of emotional variation, a reduction in ability to feel happy, a reduction in ability to feel sad. So it's an emotional blunting. And people with apathy are frequently not motivated. And people who are not motivated frequently claim that they feel fatigue. So there's a relationship between all of these. In addition to these problems, which are common in Parkinson's disease itself, there are age-related illnesses that are common. Virtually all heart diseases and lung diseases are associated with fatigue, particularly congestive heart failure and COPD. And because these tend to occur in older people and Parkinson patients tend to be older, there is a common overlap of these. And the feeling of fatigue that people have generally can't be pinned on one particular disorder when they have more than one disorder that might be the explanation. So as best I can make out, and I've thought about this quite a bit, fatigue is a common symptom in virtually all medical and psychiatric disorders, except for one, which is mania. Obviously, people with mania would do better if they had fatigue at times, but with mania, they have a hyper amount of energy, don't sleep enough, have trouble focusing, but fatigue is not one of their problems. But in virtually everything else, fatigue is increased compared to the general population of people the same gender and same age. It's common in Parkinson's disease, affecting probably half of Parkinson patients, and it often predates the onset of the motor changes. There are no known distinguishing features that separate the fatigue from Parkinson's from the fatigue caused by other disorders, including, say, chronic pain, which is also increased in people with Parkinson's disease. And we have no objective, verifiable means to measure fatigue and to say this is pathological, this is not pathological, this is severe, this is not severe. We are dependent on the patient's self-report about how he or she feels. We do know that fatigue reduces quality of life, and in some studies, it's the single most important problem, reducing quality of life, but not in all studies. Depends on the population. Now, how do we treat fatigue? We don't have any proven interventions, okay? The most important fact that I want to stress to this audience in particular, and which I stress to doctors and caregivers in particular, is that fatigue is not a moral failing. Fatigue is part of Parkinson's disease. And if you look at how people react to fatigue in patients who have cancer, for example, in cancer patients, somewhere between 50 and 75% of people with active cancer have fatigue. In people who get radiation for their cancer, during the radiation treatment and shortly thereafter, it's probably pretty close to 100%. It may not be 100%, but it's pretty high. We expect people with infections, influenza, for example, people with COPD, we expect them to be fatigued. But for Parkinson patients, especially those who don't have advanced motor symptoms, it's often considered by the family to be a moral failing. It's often considered by the patient to be a moral failing. They feel that this is their fault. They're not trying hard enough. And of course, for some people, that's probably true. But in general, this is a physiological problem. It's related to the changing biochemistry and physiology of the brain as a result of the Parkinson's disease. Now, this, of course, raises the interesting question of, if it's related to the Parkinson's disease, how come it doesn't get better when we increase the levodopa or the other medications that help the Parkinson's disease? And the answer is, it's not related to levodopa. There are a lot of problems in Parkinson's disease that are not related to levodopa. Constipation is not related to that. Posture is not related. Freezing when you walk is not related. Balance problems are not related. Speech problems are not related. Depression is not related. There are a lot of problems in Parkinson's disease that are not related to levodopa. And the fact that we can treat the motor symptoms doesn't mean that we can treat the fatigue. And what I learned with my first patient was that here was a guy who had very mild motor symptoms, and yet he was very much affected by fatigue. And yet I've seen patients who can barely walk. They use a wheelchair most of the time. They are stiff, they are slow, and yet they don't have fatigue. So although there's some association between fatigue and motor impairment, it's not terribly strong. And you will see patients with very mild Parkinson's disease who have severe fatigue, and people with severe Parkinson's who have no fatigue. So it's not simply related to how severe they are. And in fact, a colleague and I did a study many years ago looking at whether fatigue might in fact be a physiological problem, that I thought it might be related to a physiological change in which people with Parkinson's disease were just less efficient at using their muscles. And we measured energy utilization to do tasks. Basically, they were riding an exercise bicycle. and we measured their oxygen consumption for the amount of energy that they used. And there was no difference. So that it wasn't related to any type of motor physiology that probably is related to some type of change in the brain, but it's nothing that we've recognized yet. So the first important take-home message, the most important, is that fatigue in Parkinson's is not a moral failing. Telling a person to be more positive, to try harder, may help up to a small point, but it's not the major problem. So it's important for the patient to accommodate to the fact that they have limitations. As we age, we find that we have to accommodate to our limitations. We can't run as fast. We can't move as fast. Sometimes we can't think as fast. Certainly our memories decline to a certain degree. You have to accommodate. You're not 25 anymore. And now you have Parkinson's disease. So fatigue is another problem that people have to adjust to, just like they adjust to their slowness and make plans to just take longer to do things. It's not a moral failure. In terms of treating it, besides coming to some accommodation of understanding that it's part of the illness, we recommend trying to reduce medicines that are used for sleepiness, because even as I pointed out, the sleepiness is different than fatigue. There is some overlap. Anxiety medicine sometimes will make people sleepy. The Parkinson medicines too may be playing a role, although it's usually impossible to reduce them. Obviously, try to have a regular sleep schedule and sleep better, and try to increase exercise. There are data from other disorders where fatigue has been treated by exercise programs, but I think this needs to be done gradually. So it's a very slow, incremental approach to increasing endurance, which will hopefully translate into a feeling of increased energy. And then if there are other problems which are so common in Parkinson's disease, like depression, like anxiety, like pain, which themselves may cause fatigue, obviously we try to treat them as well. I also use stimulant medications, but there really are no data to support that. So I think that they are safe at low doses, even for old people. They are contraindicated in people who have certain types of heart disease or uncontrolled hypertension. But I think low doses of stimulant drugs, drugs like methylphenidate, which is Ritalin, drugs like Adderall, which is amphetamine salts, drugs like dexedrine, are drugs that, as I said, in low doses can be sometimes helpful. I've not had any problem with addiction. Those drugs can be addictive, and there are people who use that drug as a drug of self-stimulation and can be abused. I've not run into that problem in 2 or 3 decades of using the drug. So I think they're safe as long as they're used in low doses, but you need to be aware that they are not approved for that indication, and many doctors will be reluctant to use them and will consider them unsafe. However, I think it's something that should be considered, especially when fatigue is severe. And finally, I would just, you've probably gotten a notice about this before, but I wrote a book which is free. There's no advertising, there are no signups required. Certainly it's free, has a lot of links to videos. And so it's, all you have to do is click on it and you see the link. It's not a published book, and I recommend taking a look at it. It does have a section on fatigue and on non-motor as well as motor symptoms in Parkinson's disease. So I will go back, and if there are questions, I'd be happy to try to answer them. Should I stop my sharing now, Anissa?
Yeah, if you would, it might just make it easier for us to see everybody. And we did get several questions. Um, and someone was asking for the link for the digital book. So we will put that up on the
Okay.
chat.
They can
I know
also
I
just
have it.
they can also just do a Google search for free guide to Parkinson's disease. It'll come up there too.
Okay, fabulous. So there's a lot of questions, because there seems to be not necessarily confusion, but like there's an overlap of what's fatigue, what's sleepiness. One question was, should people that are experiencing significant issues have sleep studies done? Is that something that you recommend?
I think it depends on the situation. It depends on how well you and your doctor can identify the sleep disorder. So if you're waking up, say, 3-4 times a night to go to the bathroom, I don't think you need a sleep study. You need a urologist. Okay. If you have snoring and your bed partner or somebody in the next room hears you snoring and the house is vibrating, you may need a sleep study to document that you might have sleep apnea, because snoring may be caused by a collapse of the trachea, and that can be treated with certain apparatus, with a CPAP mask. There are people who have REM sleep behavior disorder, so they act out their dreams. They punch or kick. They may jump out of bed. That may wake them up, and that can be treated with melatonin or with a prescription drug, clonazepam. So I think it depends on what the sleep problem is, and that would require the doctor interpreting, what you say and describing it. When you have a sleep problem, it's very helpful, if you can, to have a caregiver also describe what they see as the sleep problem.
And you did mention the use of stimulants, which was going to be a question to ask you. So you answered that, but there was another question that came in regards to anything regarding diet that could be helpful, higher protein, anything
that's an interesting question. I think avoiding alcohol in the evening is probably the number one thing. I think that not eating much at night after dinner would be another thing. Outside of that, I'm not aware. I mean, obviously stay off caffeinated beverages, from the afternoon on. That's just common sense. The recommendations for what's called sleep hygiene are to try to have regular sleep hours, to try to exercise, but not at night, exercise during the day or in the morning, to not drink much from dinner on so you don't have to wake up to urinate, not to drink alcohol at night. But diet, I don't think I'm not aware of diet being an important factor.
One person asked or said, I'm able to get up fine during the day and get going, but throughout the day they run out of steam. So by later the afternoon, they fall asleep while watching TV, but they don't feel sleepy during the day. They're getting 8 to 9 hours of sleep each night. So is this fatigue or sleepiness?
I would say from that description, it's sleepiness. Okay, it may be related to medications. It may be that the 8 or 9 hours that you're getting of sleep are not really good sleep. And that's the type of problem that, depending on what medications you're also taking, that's the kind of problem where a sleep study may be helpful, because it may turn out that those 8 or 9 hours of sleep is really not high quality sleep.
And this was an interesting one that I think many people might have a question about. This person says their husband spends most of their day with their eyes closed and their head down, but it's not napping. Is that fatigue or is that an eye problem?
Yeah, I would ask the husband. So that is something that I've heard. Okay. And In some cases, the person really is asleep, but you can tell because you can, just ask him if he's awake. And if it looks like, if you're waking him up, usually there's some type of startle response. Or if the TV's on, you can ask the person, if they know what was going on television. So sometimes you can't tell just by looking at them, although sometimes with the breathing rate, you might be able to say. I think that for patients who are not asleep, who keep their eyes closed, but who can open their eyes, okay? There is a condition where people have difficulty opening their eyes, but then if they want to, they'll just take their fingers and open their eyes physically in order to do it. So it sounds like that's not happening. But usually in a case like this, if the person is actually awake, they're usually apathetic or depressed. So apathetic means they're not interested. They're not depressed, but they're never happy. They just don't care about anything, and they don't care about what's going on in the world. And there may not be anything going on in their mind either. It's not like they are totally preoccupied with their thoughts of whatever, what they could have done differently in their life, or better times in their life, or having, very exciting daydreams. Usually there's nothing going on. It's sort of a blank slate. Or they could be depressed. They just don't want to interact with the world because they just feel miserable. So I think the answer to that would come from the doctor interviewing the patient to explain what's going on during these spells, and the spouse, asking the patient at the time, what are you thinking? How do you feel? And then testing whether they're really awake or not. And if it's sleep, if they're sleeping like that, then that's another case where a sleep study might be very useful.
So earlier you said that people can start feeling that fatigue even before the motor symptoms might be indicated, or they might recognize them. So is fatigue potentially a prodromal symptom?
Well, there's been a lot of focus, as you're well aware, of trying to identify people who are at greater risk for Parkinson's disease. And the problem is that, with the one exception of REM sleep behavior disorder, the other prodromal features are so common in the general population that I don't think they're terribly useful. If you wanted to do a study of prodromal Parkinson's, are you going to recruit for, say, people who are constipated, depressed, sleepy, fatigued? Most of the patients you get are going to not have Parkinson's ever. It's just that, what percentage of the population is constipated? I don't know. But if you look at what percentage of the population is fatigued, well, I gave you the number of 5 to 10%, but as you get older, it's higher. So it might be 15% of old people have fatigue. So I'm not a big fan of the identifying prodromal features other than the ones like REM sleep behavior disorder, which really mean you have a very strong chance of developing Parkinson's disease.
All right, David just wrote in a question, and it actually goes along with another one. So his question is differentiating between muscle fatigue and overall fatigue. I get muscle fatigue in my left forearm from tremor. I'm taking my patients through exercise. The fatigue becomes painful. And then the additional of, if exercise is helpful to combat fatigue, but you have that type of fatigue, what do you do?
Yeah, that's not such a rare complaint, where people will complain, especially of discomfort in their forearm because of the tremor in their hand. And people also feel, tightness in their large muscles, the muscles in their thighs, and the muscles in their shoulders. And the treatment for that really is to treat the Parkinson's disease motor symptoms. So you're using drugs for treating the motor problems of Parkinson's disease. You might have to increase levodopa. You might have to add a dopamine agonist. You might have to do something. For the tremor, there are people who are occasionally using Botox botulinum toxin. It's not just Botox, that's one brand. But botulinum toxin is being used by some people for treating tremor. And it would certainly relieve some of the discomfort that people get, particularly from tight muscles. The problem with it, of course, is that you get some degree of weakness as well. And Parkinson patients feel weak frequently as a result of their Parkinson's disease. They're not weak, but they feel weak when they can't coordinate their muscles as they used to. So that's muscle fatigue, and that's treated with medicines for the motor symptoms of Parkinson's disease and the possible use of botulinum toxin. I've never used botulinum toxin for that, and I would have a great reluctance because you need to use your fingers and your hands so much during the day that I think the problems that you cause may be worse, but it might be worth a try, just once to see whether it's a good idea or not.
Well, we have so many questions that are really good that unfortunately we're not going to get to. I might need to have you do a follow-up, maybe a Q&A for one of our newsletters, because these are really good questions. And obviously this is a very important topic for people, certainly is a quality of life issue for many. So I hopefully can do some follow-up on that. But I want to thank you so much for sharing this information. This has been very informative, very helpful, trying to figure out what's sleepy, what's fatigue. So I want to just thank you and ask everyone if they would be willing to share their wave of gratitude with you. And we're so glad everybody tuned in for this talk today. We want to thank you, Dr. Friedman. I want to thank everybody for coming and giving us your time this afternoon. And we will see you all soon.
Okay, thank you for the invitation. It was a pleasure to be here. I'd be delighted to return. Thanks.
Awesome.
Bye-bye.
Thank you. Bye-bye.